Yes, yes. Thank you. We are recording this meeting this morning, just FYI. And good morning, everyone. My name is Simone Phillips, and I am the MATEC training coordinator for the St. Louis area. And I have the distinct pleasure and privilege of moderating this morning's presentation. I am assisted and supported by Beta Kashani McCroy. Beta, wave your hand. She is the MATEC manager, and also Ashley Johnson, who is a MATEC training specialist. These are the names that you see coming through on your emails, and you get the opportunity to put a face with the name. This morning, we have brought to you two speakers that are near and dear to our hearts. They have supported us on many projects and are both great community advocates. So, without delaying us, I'd love to tell you a little bit about who they are. But before I do, I just want to send you first, a hearty welcome. Secondly, to let you know that we do have some opportunities for you to participate. So if you have your cell phone nearby, that's helpful and useful to you. And lastly, that Ashley will be placing an evaluation link at the end. So don't log off before you click that link and respond to those brief questions. That will be hugely helpful to us this morning. Okay. Oh, yes. You click that on your screen. So if you're still seeing this meeting will be recorded, that is, you can click the little X and that will disappear for you. So without further ado, let me go ahead and tell you about our speakers today. The first is Tyrell Manning. He is a native of St. Louis, Missouri. He currently works for Williams and Associates Incorporated as an early intervention outreach specialist. His work is deeply rooted in community-centered advocacy for those who exist along the margins of society. This influences every aspect of his work, whether it's connecting a community member to resources to better their health outcomes or creating space for the Black LGBTQ community to simply exist. He is deeply devoted to the holistic wellness of Black gay and bisexual men. He continues to work selflessly to help his community overcome stigma and bias from all fronts. So y'all give some jazz hands for Tyrell Manning. Thank you. And secondly, we have Rashaan Gilmore. He is an he is a serial entrepreneur, community connector, organizer, and collaborator. He uses his candor, intelligence, and wit to empower individuals to assert their right to be visible and thrive. He is the founder of BlaqOut, a grassroots organization which seeks to mobilize the Black LGBTQ community in Kansas City, Missouri. Gilmore's keen insights and vast professional experience establishes him as a sought after cultural and political analyst and commentator on television, online, and on the radio, where he is host and executive producer of the live broadcast public affairs radio show Unbossed and Unbothered with Rashaan, which airs weekly on KKFI 90.1 FM. So y'all give Rashaan Gilmore some jazz hands and let's get started. We're going to turn it over to you both now to lead us into our morning's presentation.
Awesome. Thank you so much, Simone. I'm excited to be here. I first want to start off and just simply say that this presentation is definitely rooted, of course, in um, knowledge, education, and things, but it's also deeply, deeply rooted in experience as a Black same gender loving man. And so with that, today we're going to spend some time just kind of understanding the impact of HIV amongst Black MSM, Also identifying strategies and best practices for recruiting and engaging Black MSM with pre-exposure prophylaxis or PrEP. And we're going to discuss perceived ideas about Black MSM and PrEP uptake, and then take some time to understand how you can actually improve some of your PrEP messaging and what that looks like in your own work and organizations where you are. And so I will first start with just simply talking about HIV and Black MSM. I think that we all know that like that's a relationship that exists. As a Black MSM, I think that we learned very early about HIV. I think even in my own coming out, before I ever even knew and was ready to experience what it was to be a Black gay man, it was Tyrell, you're going to get HIV, or Tyrell, don't get HIV. And so I think that Black MSM, we are deeply, deeply connected to HIV, and we have carried the weight of this very early in the HIV epidemic, before, people even were doing actual work to like kind of mitigate the issues of HIV in the Black gay community. And so basically in this, just that understanding that, often we are perceived as like Black MSM and HIV are kind of hand in hand. And within that, there are people that exists in that, and we're a bit more than just HIV. And so we just kind of want to talk about that, and just kind of shed light and understand that, like, why are we in this space where, we are so disproportionately impacted by HIV? So we can go to the next slide. And so, as we know, we have carried that weight. But between 2014 to 2018, the CDC reported a lot of shifts with HIV, and this is kind of after PrEP came along and things of that nature. And we saw some decreases, to where, first of all, in 2018, about 3 out of 4 Black gay and bisexual men actually received HIV diagnosis between the ages of 13 to 34. And we see this major disparity if you look at this chart between, our other counterparts, between our Hispanic counterparts who are also gravely impacted by this disease as well. But we also just want to really understand that, like, there were shifts, which you'll see in my next slide, but even with the shifts and some of the changes and the tides, Black MSM still carry a major weight of the HIV burden in our country. Go to the next slide. And so between 2014 to 2018, we did see a dip in 13 to 24, about 17%, but there was a 12% increase between 25 and 34-year-olds, whereas as we got higher, we saw some stabilizing and a little bit of decreasing. But today we really want to focus on like that increase, and understanding that, again, and I'm going to say it again, and it'll be repetitious, there is still work to do, right? There's still heavy work to do, and work that needs to be intentional and strategic when it comes to mitigating this problem within our community. And we'll go to the next slide. I'm going to move through some of these. And so, we all, if you've done this work, you all know that the CDC reported that 1 in 2 Black gay and bisexual men will have a lifetime risk of being diagnosed with HIV in their lifetime, of course. And so with this, again, there's work to do. We cannot, just kind of go about doing work around HIV without, honestly, like, not just highlighting, but being very intentional about how we work with Black MSM, because we are carrying the burden of this, and there needs to be work that is very specific to us. And so I'm going to hand it over to Rashaan a little bit to kind of explain a little bit of why is this happening? Why do we see so much, such a disparity, in a sense, within Black MSM?
Thank you, Tyrell, and good morning, everyone. I'm so happy to be here. One of the things that I think often gets confused, or at least conflated with other issues, is the perception that Black same-gender loving men, or Black men who have sex with men, are more quote unquote promiscuous, who are more risky in their sexual behavior. But what we know from numerous studies is that Black men who have sex with men report higher rates of condom usage and condom efficacy than any other social or ethnic demographic. And so it's not an issue of Black queer men not taking care of their healthcare as much as it is an issue of prevalence. And because there's higher prevalence of HIV in a smaller network of individuals who are oftentimes, whether they know it or not, sharing the same sexual partners, you see a proliferation in ways that you don't see in other communities. And so Tyrell mentioned about that CDC projection that unless something changed, fully half, 1 in 2 out of every Black queer men will contract HIV in their lifetime. And so clearly PrEP as a means of helping to end the epidemic is absolutely crucial, and access to PrEP has to be significantly enhanced and increased, not only in our communities, but around the country, not just here in Kansas City and throughout Missouri. I will also add that when we talk about PrEP, you can go to the next slide. Most people have a lot of misconceptions about what PrEP is and what PrEP does. And those misperceptions don't only exist within the community, they also exist among many providers. And so later on in the presentation, we'll talk a little bit more about some of the barriers that Black MSM encounter when thinking about getting on PrEP or when they try to get onto PrEP. So PrEP is pre-exposure prophylaxis. It is a once-a-day pill that you take to prevent contraction of HIV. The first drug approved by the FDA for PrEP was Truvada in 2012, made by pharmaceutical manufacturer Gilead. And its follow-on, Descovy, was approved by the FDA in 2019. But what we know is that when taken effectively, which means every day, consistently, it will help people who are not living with HIV to remain that way. PrEP is 99% effective when used daily, and 74% effective when used daily if you're a person who is engaged in any sort of needle sharing and that sort of thing. And I will just say that one of the things that I think is really important to understand is that people's understanding of PrEP has changed quite a bit, and there are other crosswinds that are impacting PrEP uptake among our population. One of the things that I think is a strong crosswind is some of the lawsuits that have been filed on behalf of plaintiffs, but we know that in very rare instances, issues of bone density, particularly among Latinx men, and issues of kidney or high creatinine levels do sort of predominate, but that is not always commonly the case. And so I just want to get some of the information out there about these myths that are out there for us to talk about them some more. Tyrell and I want to do a little quick knowledge check for you to see what you know about PrEP. So follow the information on screen here for a quick little knowledge check. Go to menti.com and enter the code 5171. And I lost it off the screen, but hopefully you all can still see that. And join us for that knowledge check. So which drugs are currently approved for PrEP use? We just shared this on the prior slide. Stribild and Truvada, Descovy and Complera, Truvada and Descovy, or Cabotegravir and Biktarvy.
Thank you, Rashaan. If you're trying to remember where to go, it's right at this top of the slide at www.menti.com. And then you'll be prompted to enter the code 5171-4638. And then you can respond. We'll give you a couple of seconds to do that.
Looks like a very bright group here.
Thinking of one of those old sex ed videos of the sperms attacking the egg.
Hey, Stephen Wilson, it's been a while. How are you?
That is funny. That is so, I can remember those.
That is what it looks like.
So we have almost half. Want to give you all a few more of you an opportunity to reply. Thank you. I said you'll have another opportunity to participate, so keep your phone nearby. Thank you, and I'll turn it back over to you, Rashaan and Tyrell.
Awesome, thank you. On the next slide that you're about to see, we want to just kind of open up a discussion about the relationship between Black men who have sex with men and PrEP. And I do want to stipulate that the term men who have sex with men was not a term that the community, particularly among Black queer men, gave to ourselves. That was a term that originated with scientists and programmers at the CDC. So I want to put that out there. Tyrell, we talk a lot in our conversations about the communities that we serve and some of the barriers that they run into, not only from the side of the patient seeking to understand more about PrEP or to get access to PrEP, but even from providers who, many of whom still don't have a great deal of knowledge about what PrEP is, how it works, and whether or not they can prescribe it for their patients based on their particular area of specialty. And so I just wanted to ask you your thoughts, Tyrell, about what you think are the major issues. And I see some folks are still voting. We're going to give you that answer here in a little bit to the knowledge check question, by the way.
Awesome. Thank you, Rashaan. So actually on the next slide, and this ties completely together, we actually talk about how like so often when Black MSM are going to doctors and things of that nature, you know, we aren't always getting the full information, right? Doctors aren't talking to us about it, right? And so we have this, you know, report here that says that 40% of white, gay, and bisexual, you know, men were using PrEP in 2017, while only 30% of Latino, and then 20% of African Americans were using it. And, you know, the question is why? You know, why is that happening? And I think that for me, a lot of times in this work, I think that we try so hard to do this work of kind of leveling this playing field, right? Of like, we just need to be doing the same thing, or even if we get grants, we're not always going above and beyond, even if it's specific to Black MSM, you know? And so I think that when we're doing the work of like getting PrEP promotion and educating our doctors and spaces around PrEP, we need to be making sure that that is specific and intentional to Black MSM and is almost going above and beyond the work that you would do for our counterparts. Because if we want to have those conversations and we want to see those numbers go up, you know, we have to have conversations in doctors' offices. We have to have images. We have to have sometimes, you know, and I'll talk about this a little later in a bit, so I won't go down that road, but we have to have actual work that is done to actually kind of uplift that, right? And so we go to the next slide. We'll see that many, you know, a lot of people report it here when it switches to the next slide, that when it comes to PrEP awareness, Black MSM actually, and even our Hispanic MSM are actually reporting lower instances of PrEP awareness. They're not having those discussions with their health care providers, and there's, you know, their PrEP use, of course, is down. And I think often, you know, we have so many different perceived ideas. Why is this happening? Why don't they want to take it? But if you're not talking to them about it, you know, if we come in with like prejudgments and like, you know, a lot of times when we're walking in, Rashaan, like it's kind of like I've come into this space and I think about my own time when I, you know, went to like a new primary care physician. The first thing he found, you know, said when he found out I was like a Black gay man was, oh, I'm going to give you an HIV test. You know, you need to take PrEP. And I was like, well, pause, you know, let's have further conversation, you know, because there's this instant mindset that you're a Black MSM. I need to somehow, you know, fix you and get you on PrEP, instead of having a conversation with me about the types of sex that I'm having, how I desire to navigate that. What are my desired ways in which I want to navigate sex, right? And so, Rashaan, let's discuss this next slide together. I want to pause to hear your voice, but also I think this leads perfectly into our next slide. First, our conversation, our test here.
Which I'm really excited about because there's several things. And
Yes.
As we walk through this dialogue, one of the things that I'm going to be doing is sharing my top 10 reasons, or the reasons that I have seen patients, including myself, not get on PrEP or stay on PrEP. So don't worry, we're going to leave you with some very clear specifics and how to begin addressing those. But we're curious, why do you think Black men who have sex with men aren't taking PrEP at the numbers that we see among our counterparts? And I'll throw something else out to you. In 2018, BlaqOut conducted a community health needs assessment among the Black LGBT community here in Kansas City, specifically focused on 18 to 34-year-old men who have sex with men. And we asked them about their PrEP knowledge and about their PrEP usage and uptake. Here's what we found. 87.1% of our 234 survey respondents had heard of PrEP, but only 11.5% had ever been on PrEP. And of that 11.5%, only 5.9% remained on PrEP prior to further than 90 days. And of those, only 1.7% up to a year. So we needed to really dig into the sort of metadata here and figure out what was going on and why is it happening. So as we talk through this question, I'll come back in a little bit and give you the answers to my top 10 reasons why Black MSM aren't taking PrEP at the rate that many others are. And you're going to begin to see a little word cloud formulate here as you provide your responses to that question.
We have some great responses coming in.
I love that you're all so engaged at 8 o'clock in the morning. I really appreciate it. It's not easy for a lot of folk.
Stigma.
Wow. And obviously, the larger the letters, the words appear, that shows the more often those words came up in the responses that you all are submitting.
Yes. I'm going to just kind of like name some of the ones here. So we of course have stigma as the center, follow-up care, lack of access, lack of health care, the financial burden, lack of information, no intentional outreach, medical mistrust.
Big one.
Yeah. No social network. Afraid.
Ashamed.
Yeah. These are awesome. No insurance. Provider bias.
I cannot say that I am even remotely surprised that stigma factors in most heavily. But we're going to talk about that from a couple of different angles, the stigma piece. Okay, I think we're probably pretty good on our responses there. And as we make our way back to the slide deck, why aren't Black MSM taking PrEP? Or I'd like to add on to that, taking PrEP at the rates of other ethnic groups. Some of the responses that you all gave show up here on this very list. Stigma and shame, we saw that was rather pronounced in that word cloud. Bias, we can talk some more about that. Medical mistrust and mishandling is a huge one. Lack of PrEP savvy, sex positive providers, low income, uninsured or underinsured, lab costs, copays and provider costs, socioeconomic challenges, and they don't want to. And sort of my rundown, if I were to sort of put these in order, Tyrell, my usual approach to this, based on what we have seen and experienced with all of the many patients that we have on PrEP here at BlaqOut, is that number one is side effects, or the perception around side effects, that they won't be able to drink anymore if they like to have alcohol, because PrEP can be, the drugs in PrEP can be pretty strong in terms of your kidney function. So a lot of people worry about liver and kidney function. Number two is adherence. Although women do this all the time, or female bodied persons do this all the time, men don't do so good at it. And that is to take a pill every day for something you don't have. For women, it's called birth control. And very often men struggle with the notion of taking a pill every day for something that they do not have. So one is side effects, two is adherence, three is stigma. And sometimes that stigma comes from providers. Providers sometimes will say, oh, I don't do that, or just don't have as much sex, I don't know enough about it. Go over there to one of those STD clinics and they can help you out. And also perception of being perceived as a hoe or someone who is sexually promiscuous is a big factor there. Access is a big one, and affordability. When it comes to access, people just often don't know where to go to even get started. We just saw a patient in yesterday who told us that he called one of those 800 numbers, saw an ad on social media, called one of those companies, and they told him it was going to be $800 to get started on PrEP. PrEP need not come at any cost, the medication itself. However, there are costs around provider visits, lab copays, so on and so forth, or lab costs, and that's a big deal. Affordability is also a factor for those who don't know how to access or navigate the payment programs available through Gilead Advancing Access or Payment Assistance Foundation. Medical mistrust is big, and we saw this throughout the pandemic, even around the COVID vaccines, where many people from the Black community writ large are like, we're gonna hold off and make sure we know this is all right first. And if we don't see a bunch of folks, dropping like flies, then we'll take up, the vaccine. But that's because of a history of medical trust. And you might not think that younger queer people or men who are having sex with men are aware of Tuskegee Institute experiments and so forth. They are. They absolutely are. The last couple of things, self-care. Sometimes people are very fatalistic in their approach to their self-care and to their sexual health. If it's going to happen, it's going to happen. And so sometimes that's a big factor. Also, safety. Not everybody is in a position to have autonomy over their own body and decisions. Sometimes in serodiscordant couples, we've seen this, Tyrell, where one partner is living with HIV, one partner is not living with HIV, but the HIV positive partner is in more control in the relationship. And that's an issue of trust. You should trust me that I would never harm you. You should trust me that I'm taking my medication as I should and being adherent to my treatment plan. So that person may not be in a position to do so. And then lastly, messaging and choice. Just what we see at the final bullet here. Sometimes people just don't want to, and no amount of browbeating them into it is going to make them do it. So the key is to just be available to them when they are ready.
Yeah. And I would even add to that for myself, if I can be like vulnerable in this space a little bit, I definitely started PrEP when I was in relationship with, people who were living with HIV, and then we broke up. And so for me, PrEP no longer, served a purpose for me. I personally know how to navigate, my own sexual wellness and things of that nature. And I think often, we don't trust that Black MSM know how to care for themselves or be responsible for their health, that somehow we have to like give them this item in order to keep them. And it's a great tool. And I think that it is still an option for me in the future, but I think giving us the autonomy to make decisions and offer us other methods, right? So the next slide. So with that, and I've kind of mentioned this before, that it is important, and I'm going to quote this here, that the goal shouldn't be to make PrEP use equal for Black MSM or African American or Hispanic and white. It needs to be going above and beyond to make sure that we are highlighting, if we are going to do the work of getting PrEP into Black MSM communities, that needs to be the top focus. It cannot be centered around making it equal or doing it. We need to be going above and beyond. And I'll move to this next study here that was done. And this is the first study with the networks, HIV Prevention Trial Network, that was literally done for everybody that participated in this. All the principal investigators, the decision makers were all Black MSM, and I'm not going to like read the slides. I'm not a presenter that reads everybody, I'll just kind of go through, but they did this work of bringing Black MSM together and providing them with PrEP education, providing them with PrEP, providing them with resources and support. After that, so they were following up, getting them connected to referrals, doing linkage to other things. It wasn't just simply, let me get you on PrEP and go home, and I'm going to follow up with you in 3 to 6 months for your, creatinine checkups and things of that nature. I think that if we are going to do that work, it has to be extensive. It has to be at times, creating these spaces that are, I'm not just bringing you here, but I'm assessing what are barriers that might keep you from, taking up PrEP. What does that look like for you? And so really creating culturally competent supportive services to support PrEP use. We can go to the next slide. And so, when these people were presented with these choices and these opportunities or whatever to not just take PrEP, but also like they were given the autonomy, like, what does your sexual wellness look like to you? Let's get you on PrEP. Let's support you, in what you need. Let's connect you to resources. Some of the participants were in North Carolina, I believe, and access to resources there were much lower than the ones in, DC or California. And so they had to do more work to create referrals, create resources, because there were other needs that, these community members needed beyond just let us get you on PrEP. And so with that, I think that, again, we need to be really focused on creating culturally competent supportive services. I think of my work at my job, I'm early intervention services. I'm working with people who are living with HIV, who are struggling with their medicine adherence, struggling with getting to the doctor. It is my job to support them and assess, barriers and things. And so I think we need things similar for those who are, who basically we want to take PrEP, that like we have to be very, very serious about how we go about that. And so next, we're actually going to talk a little bit about that PrEP promotion, specifically equity-based PrEP promotion. And I feel like, Rashaan, we're going to kind of like go back and forth with this.
This will definitely be a tag team.
Yes. So I really like, there's some questions that exist here. So like, what images are hanging in your clinic? I think often I've been to clinics where, that to be plain, there were white men everywhere. There were white gay men on the walls, or there were cisgender people, or if there were Black people, they still didn't look like me, right? They were typically possibly lighter skin, or they all had a muscles and a six pack, and I don't have that yet. And so I think that when we are putting images and things, right, and that's not just hanging on walls, but in your pamphlets and your brochures and the messagings, how are you talking about Black MSM? And I know we're using Black MSM in this space. I don't use that word when I'm not here. Don't use that word with Black MSM, with Black same gender love men. Ask them, talk to them, and be more relatable, right? How are you approaching conversations about PrEP? I think, and I mentioned before, my own doctor, it was like, oh, he found out I'm a Black gay man. Oh, we need to get you an HIV test, without asking me the fact that I do that every 3 to 6 months. Rashaan, I see you look like you have a word.
I was just thinking that one of the challenges is that as, sort of practitioners of HIV prevention on one side of it, we approach PrEP for what it technically is. It is an HIV prevention tool.
Yes.
The problem with that is that is not how the community views or perceives it. And so even here at BlaqOut, we've had a shift in how we approach our own messaging, and including the language, but also the imagery. So those are two things to really keep in mind. But at the core of all of our messaging around PrEP is not PrEP as a prevention tool, which can, by the way, be sometimes, if we're not careful, stigmatizing to people living with HIV.
Yeah.
That's one thing to be said. But also, we look at PrEP as an empowerment tool. So we talk to people about PrEP in terms of empowering their control, their choice over their sexual lives and history and story. And so that makes the biggest impact in my mind, how we are actually talking to people about PrEP. So there's no shame associated with it. There's also, in the imagery that we're putting in our materials and the language that we're using, it really is about reaffirming their right to choice, this being a tool to empower that choice, and that we are there to support them in making that choice for as long as they make it. And I say that because, as Tyrell mentioned, risk factors for PrEP do change based on what you're currently doing. If you're not sexually active, then maybe PrEP is not something you need to be taking every day if you know that you're not going to be sexually active. But other things that we talk to folk about when it comes to PrEP is making sure that they are aware of the fact that there are other ways to take PrEP, and considering PrEP on demand, right? PrEP 211, that is incidence-based PrEP take usage. So you might take 2 pills 2 to 24 hours before having sex, and then 1 pill each of the next 2 days after that. And that may be a better way to approach PrEP usage for some who are not interested in a daily pill regimen.
Yes. Yeah. Thank you for that, Rashaan. And I also think, who are you using to promote PrEP? And this is specific to like this quote next to this slide here, that, when we often are trying to like promote PrEP and things of that nature, we typically go out and we find the ones that are either coming to us, which is, I understand they come to us, it's easy, we find those people. We need to be doing work to say like, hey, let's like build some social networking strategies, go out, bring your friends, compensating them for that work, building outreach networks and things of that nature, so that we are not just, going out and finding people that are close and easy for us to reach. Because this is deeply personal for me. Oftentimes we say, and Black MSM is like a hard to reach population. I personally disagree. I think that if you are not doing the work, because we don't all look the same, we don't all act the same, we don't all dress the same, go the same places, getting various different Black MSM working with your team, working within your agencies and working with you to like do that outreach, because we all look different. If you have, you know, an organization that's strictly working with ball community, that's what they're going to get, you know. But if you want to go out and you need to build bridges and getting that variety in your outreach. And again, are you compensating them? So often Black MSM are used for free. We are used for our services. We are, you know,
And our
asked the
trans siblings, I want to throw that in there too.
and our trans, definitely our trans, if not worse, for our trans sisters and brothers, like used for our services, our questions, our minds. Even when you hire them at your agency, I charge you to pay them well, compensate them well, because these are still, you know, and I'm not saying this in a way that we don't acknowledge that, but so again, often for me in this work, we become numbers, we become a word in a grant, we become a target population, a focus population, and not humans.
I want to
Right?
jump in just really briefly and
Go ahead.
respond to some of the comments in the
Go
chat
ahead.
box. Paisley at Casey Care asked a really great question, which is, can those who are in positions such as educators, specialists, I assume navigators, PrEP navigators, legally promote 211, or is that more so for providers to do? And so 211 came out of a study, and the CDC does promote 211 as a PrEP uptake methodology, and we certainly do as well. Many providers have not heard of it, but we've been training our providers on PrEP 211 so that when they do provider visits, particularly with new PrEP initiates, that they provide that as a resource for them as well.
I love questions. I love questions. So let me see. So then lastly on this slide here, who is leading the planning and strategizing around reaching Black MSM? Again, you know, if you're going to go out and you're going to reach, you know, possibly, definitely at the top of that should be making sure that Black queer men, Black trans women, whoever you're reaching is in that, a part of that, leading that. And so, yeah, so those are the equity-based PrEP promotional pieces there. I want us also to kind of go over to the next slide where we'll do a little bit more examining. While you're doing this, we need to be looking at, again, the images that we have, right? And here we see all these very beautiful images, all Black, gay, bisexual men. There are images out there, right? If you are planning on making your own, make sure that you get a plethora of body types, a plethora of shades, because, you know, Black people, we have this power of coming in varied shades. You know, just making sure that we are all seen when you have this, right? Because even with the ones that are here on our screen, and I keep mentioning this, but like for the most part, everybody here pretty much looks the same. You know, making sure that we have varied body types, varied, you know, identities represented when we are, even when it's specifically to Black MSM, because we are not a monolithic group. Rashaan, did you have anything to say about that?
Yes, just that if you'll notice on some of the images that we have up here, there are some different attempts at being approachable and accessible and relevant. That's key. I just want to encourage everybody to be as innovative as possible. Really listen to your community and understand that many of the same or traditional channels that you use to market to community may not work with trying to reach out to Black same gender loving men. And a good reason for that is because they're bombarded. We have been problematized. And what I mean by that is it almost feels like sometimes we are the problem. We are the reason why there's HIV. We are the reason why numbers may go up. And it's not based on the fact of, as I said earlier, around issues of prevalence, access, affordability, so on and so forth. So I would just say that the key here is to be as creative as possible. And in some cases, I know it's very difficult when you are working within agencies that maybe serve other communities and they want to have this sort of broader rainbow approach to it. You're saying Black Lives Matter, and the response from your leadership leadership is more like all lives matter, but you're going to have very targeted messaging that comes from and that relates to the community that you're trying to reach. And I will just say this one last thing. Black same gender loving men are very media savvy, and they're going to see through any messages that are superficial or just intended to bait them in. If when they show up at your clinics, so they show up at your programs, they don't get that same sense of acceptance and warmth, then you're going to lose them very quickly. So from the messaging all the way through to delivery, you have to be consistent.
Yeah, very much. And that's, for me, from like who is at your front desk, who is greeting them, who is like working with them, you know, throughout the entire process is highly important. And so, which takes us perfectly into our next slide, which is simply examining. We need to take time to examine some things that we all have to navigate at different levels. Our assumptions around Black MSM. I feel like we talked about that a lot this, morning. I almost said this evening, but talking about that because we do have assumptions. Even as a Black MSM myself, there are assumptions that I have to navigate, right? And we need to not assume that if a Black MSM comes into your office that somehow they are promiscuous, that if they say I'm a Black gay man, they're just out here doing whatever, in these streets. And that's not the case. Talking to Black MSM about their sexual wellness. And I know we have our, papers, we have our assessments and things, but going beyond that assessment at times and building conversation. This is a little sidebar, but like, I love my chiropractor, right? I come in, my chiropractor, they do a lot of questioning, right? But they don't just question me about my back. We have conversations about my mental wellness and things that I would not expect to have to talk about in a chiropractor. And so I think when we are working with Black MSM, we need to be working through some of those assumptions and going beyond, right? Confronting some of our biases, our stigma, the language that we use. I know right now we're in a season of asking people their pronouns. And I can say that in Missouri, we need to strengthen that for sure. I've been to regions where that is just the order of the day. When you greet yourself, Rashaan, it's hi, I'm Tyrell Manning. My pronouns are he, him, his, asking people that. And also our expectations of Black MSM. What are we expecting of them? And if we have those expectations, and are those things that they agree with, are we again making those assumptions? Rashaan, do you have anything to add to that? I'm trying to keep myself from going down a rabbit's trail.
Well, I same here. I know we want to leave plenty of room for questions, so I'll just be brief and say that sometimes that the stigma that the community members who come to you are worried about is stigma from peers. And that has a lot to do with it. You wouldn't need to be on PrEP if you weren't XYZ, or I don't have sex that much. And so maybe sometimes people misunderstand their own risk factors for HIV contracture. And so one of the things that I think is really important for all of us to remember is that when we do talk about examining assumptions and bias and stigma and language and expectations, yes, it can be hard. However, the key to this is to let the community lead you. I think too often we are trying to drag the community along because there's been a study released or the CDC has issued some new finding or guidance. And so we feel like we have to drag the community along that way. I want to encourage you to trust the communities that you're serving. They know best what they need, and they know best how to bridge the gap to their needs if we will just listen to them. So I'm always moved whenever I hear one of these or read one of these powerful quotes by Dr. David Melbranch. And so I know that you can read it for yourselves, but sometimes there's power in the spoken word that you don't see on the page or on the screen, as it were. So I'll quote Dr. Melbranch here. "We are much more than a hard to reach population or walking risk factors for HIV or vectors of disease transmission. We are proud Black men." If you or your agency or your program has trouble embracing that messaging, then probably trying to target this particular demographic is not going to be for you. And you should leave that work to others or bring them in to assist you. The goal here is to support Black same gender loving men and having access to and maintaining adherence to PrEP. Anything short of that is trying to drive toward numbers and grants. I see we had a question about that. We'll talk about that some more in the Q&A. But I just want to say your goal should be clear, and that goal should be to help these proud Black men have access to better healthcare.
Thank you. I think that was a beautiful wrap up to that. I guess we can open up the space, I believe, to our last question, which is, what did you learn? So that same process, enter that website, enter the code, and we want to see if you all learned or what you learned, because I'm sure you learned, but what did you learn today?
Yeah, thank you both. I just want to draw your attention to a comment or a question by Randolph in the chat, who says, how do we change the narrative since everything is so numbers and grant driven?
Yeah, I think this is a great question. And I can only speak for myself. Is, if you know me and you get to know me, I challenge a lot. And I appreciate the grant and I appreciate the numbers, but I think we have to be very purposeful and really sometimes step out beyond just the expectations of a grant, to really acknowledge and again work with the human pieces. I think you can still fulfill the numbers and be grant driven while doing the work that for me is community centered, which means that it's centered on the needs of that community. It's centered on the wants of that community, just the holistic wellness of that community that goes beyond just those numbers and that grant. And so I want to be clear, because I want my boss knocking at my door. I am not saying don't fulfill your grant, but I'm saying that you can still fulfill your grant and meet your deliverables while also keeping Black MSM and their humanity and their worth at the center of that. And so challenging some of those limits with that. Rashaan, you have something to say? Because you lead a whole organization.
And it is tricky, and I appreciate Randolph's question. Actually, if you can, Randolph, I'd love for you to share a little bit about which narrative you're talking about. But to the latter part of the question, as I understand it, when it comes to trying to meet grant numbers and deliverables, that would be great.
How you doing? I'm Randolph.
Hey, Randolph, great.
Yeah, I was just in social services in this field as at large. When you out here and you trying to promote health. Help people get to the point where they trying to go to and trying to educate and trying to empower. You see a lot of stuff numbers driven. The focal point to get services. You see a lot of it. You see a lot of that going on, and you miss the conception of people, being humans, because your focus is on, I got to get this and I got to do this. And you miss that aspect of serving people, the whole, why you in this field, and I struggle with that.
I appreciate that question, Randolph, and thank you for that clarification. I can tell you that I've been on both sides of this as a prevention practitioner, if you will, and also as the leader of an organization that survives in large part on grant funding. And there can be a huge challenge a lot of times in trying to find that perfect alignment between what the funder is seeking to accomplish with the giving that they're doing, and for the agency or individual within an agency who is trying to make a change essentially in the community and provide this access. There is alignment when there's clarity. And so the clarity in my mind has to come around from, we are telling you the stories of the people that we are serving. And so we have credibility with the audience that we're serving, and we are looking for funding that will allow us to implement unique approaches because there's urgent need and the usual tools are not working. My dad once told me that if you're a hammer, then everything you see is a nail. And so too often we are trying to use a hammer when we need a screwdriver or when we need pliers or some other tool. And so I think properly telling the story of where your specific community is, and there could be multiple communities within a broader community, but telling that story effectively and helping the funder to see that, as I always tell my board and I tell my team, data drives dollars, and the data that we are seeing says that the dollars should be going this way to this type of approach. I wish I could spend some more time with you in your question, Randolph, because I think it's a very great one. I know a lot of people struggle with that, but I think my contact information will be available later, and you certainly can reach out if you have questions.
I appreciate it. Thank you.
My pleasure. So I don't know where we are with those responses. We'll see that momentarily. I'm very eager to see what you all have learned today.
Hey, this is Paisley from KC Care. Great presentation. Thank you, MATEC, BlaqOut, and Tyrell. I just had a quick question. So we have either employees at KC Care or volunteers of KC Care who either identify as a race of Caucasian outside of being African-American or Latino. And they are basically saying, you know, I'm passionate about you all's culture. Not even like I have African-American friends, but I'm passionate about you all's culture. I understand the struggle. I want to work with you all. I'm in the field too, but I am not reaching your population. How can I do the work when I'm not reaching them? And I understand I'm here. I've been here for a long time, and I'm not able to get through to them being African-American, whether it's male or women, but for this presentation today, specifically male. So how can we help my counterparts, white providers, Caucasian, Asian friends and family, and educators and specialists be able to reach the African-American culture?
That is a beautiful and profound question, Paisley, and I appreciate it. I'm going to attempt to answer that from my perspective and my experience. You know, one of the things that I think happens a lot of times is that in the quest to be helpful, sometimes other communities may stumble in their attempts to reach out to the Black LGBT community specifically. And one of the things that I think is important to do is to try to think about it in terms of how you are an ally and to be supportive. And again, going back to what I said, it is in following. Sometimes in wanting to help, you want to lead. Well, I see that there's this need and maybe they just don't know about it. So if I can just get out there and mix it up with them, I can tell them or bring them along this way. And it comes off in a very paternalistic sort of way, and that can be extremely damaging. So if you are an individual or work with an agency and you're like, well, I'm not a part of the Black community or the Black LGBT community in any way. I may not even have friends who are, but I see this need to sort of, to Paisley's question, what I encourage you to do, what I challenge you to do is to think about how you can carefully and respectfully engage. And what that may mean or look like is talking to members of that community that you may not be a part of, and to let what they tell you guide you. Too often people show up with the answers instead of showing up with the right questions. I'm a firm believer that if you ask the right questions, you can get to the right answers. And so I just think that we have to be clear about how we show up as an ally. And sometimes allies, friends, we push so hard that we run the risk of alienating people and pushing them away. Even in our quest to help, even in our zeal to see change, we just have to be very mindful that we have to meet the community where it is and move them from there. I hope that was helpful.
I'll kind of add quickly that it's actually one thing that's very unique about my own role is that I'm actually working with and like supporting case managers that work with, you know, the MAI population. And so often I do find with a lot of like, you know, the white case managers that I work with and stuff, they often tell me that their clients and things are telling me things that they've never told them, or, you know, communicating with me. And so I think if there is a way, and this is very like future because this creates another job, but like some way where there was, you know, I don't know if that's a community health worker or another engagement specialist or an early intervention specialist like myself, that kind of creates just a mediator, I guess, or some type of support that is created to where it's like, hey, you know, you can support that person and also support whoever's working with that community member. So I don't know, just building systems of support within that agency and you know, whether it's peer support and other things that kind of buffer some of that and hopefully support that community member and being successful in whatever it's needed.
I just want to add one other thing too that I think might be helpful in response to Paisley's question. You know, I was asked several years ago by the CEO of the organization that I was working for, who was very, very supportive of all the things I was doing, but was kind of confused, like, how is this happening? And one of the things that I said to them at the time was, you know, they asked the question, well, what's the secret to the secret sauce in terms of reaching the community? And really, there is no secret to the secret sauce, but this: be relational, not transactional. Be relational,
Yes.
not transactional.
Yes.
We are always talking about our not we as in BlaqOut, because I don't allow that here, I really don't. But in general, we talk a lot about HIV prevention, the numbers and testing numbers and PrEP uptake and PrEP adherence. What we don't talk about is being relational. And
Yes.
so relationships take time. Relationships can get tricky. They can get difficult, they can get uncomfortable. So my blunt answer to Paisley's question is, if you're not fit for this and ready for the long haul of building a relationship within the Black LGBT community, do not engage. Don't start if you're looking for the quick win or the one hitter quitter. That is not going to work. Cease, desist, go a different direction. Do not pass go. Do not collect $200. You about to mess something up. So be relational, not transactional.
Yeah. And I think, because I know we have to wrap up, I think that
I'll
also
pop back on. I see Simone there, so I was on.
Yeah, so that's why I'm like, let me get this in. But I think that also connects though back to Randolph's comment around, like, also at times, you know, and I find this, that relationship piece will sometimes test that structure. It's if you are a social worker, you are bound to a set of like restrictions, right? A set of ways that you work with people, and at times, building relationships, for me, you know, that is 100% of what I do. Is I'm not just calling you to say, are you taking your medicines, but how are you? How is life? You know, and so that is going to test some things, but you have to learn and build that boundary system while also learning to build that relationship. Simone, I'm not going to say anything else.
Thank you so much. I just want to say that one, Ashley is going to place in the chat box right now the link to the evaluation. And so we need for you to click that so that we can illustrate to our funders that we've done and how we've done with this program. The second thing is both of our speakers have agreed to stay on just a few minutes after 9 a.m. to take additional questions, because we realize that this is a short amount of time. And lastly, we didn't get a chance to review all of your comments verbally here, but I hope that you got a chance to see how much learning took place in this short period of time. I want to personally thank both Tyrell and Rashaan Gilmore for being so amazing this morning and sharing these useful facts with us. Thank you all. Oh, did you see it in the chat? Okay, the evaluation link is in the chat. And listen, and so if you have additional questions, thank you for coming today. We appreciate you. And also the slides will be made available afterwards. Yes, Ashley? Okay, Ashley's nodding. The slides will be made available so you can use the resources that are there and look at the video that was embedded in the slide. Now I'll turn it back over to Tyrell and Rashaan to answer any additional questions. There are lots of thank yous in the chat box.
I just want to say thank you briefly to Simone, to Beta, and Ashley. What a dynamic team we have.
Yes.
MATEC at KC Cares. So kudos to you all for doing a great job in putting this together.
Thank you. And if you missed this presentation today, portions of it, I saw some had technical issues. On Thursday at noon, there will be an encore presentation live. It will not be the recorded version. These two will be coming back live to you in living color on Thursday at noon to do this presentation again. Thank you. All right. Were there any additional comments, slides? I see many of thank yous. You all can rock the mic now and talk with everyone.
Awesome, thank you. Yeah, I'm happy to stick around if there are any questions or respond to emails if you send one. I will admit to being slow in responding to it in advance, just to do a little level setting on expectations, but I will respond.
Thank you all so much. It's 9 a.m. We appreciate you. Again, thank you so much.
I just want to say thank you again. I love these conversations, because through these conversations, you actually learn, And,
Thank you, Randolph. Randolph, where are you located?
I'm in St. Louis. I just moved here to St. Louis. So
Okay.
I work for the Ryan White WashU University.
Wonderful, wonderful.
Well, you have to come on over to WA so I can meet you. I'll come to WashU because I'm like down the street.
Cool.
So.
All right. I got to get y'all. I don't know if your information was in the chat. We can reach out.
Yeah.
In fact, I'll drop mine in. Tyrell, you can do the same.
And it'll be on the slide. It's the last page of the slide deck.
Oh, it's the last page?
Yes. So once you complete your evaluation,
okay,
you will then receive the slides from today.
Okay, cool. Thank you.
Sure. Okay, I still see so many people here. Did you have questions? You can come on the mic. Otherwise, our program is concluded.
For those of you who remain, I'll tell you a quick little story about myself and my own PrEP journey that I like to share when I do these PrEP presentations or webinars. I've even shared this with Gilead, with a number of their training teams. I like to jokingly say that I probably should have gotten the first PrEP pill that rolled off the conveyor belt. I was an ideal candidate for PrEP, but was reluctant because even though I worked in the field and knew all the stuff and the science and the studies and the efficacy and all of that, I was still just very, very reluctant because I thought, man, I'm gonna have to be on this forever, or what are my friends, peers, and colleagues gonna say, that sort of thing. And then when I started the process of trying to actually get on PrEP, some of the PrEP clinics local, they're not that many, but the ones that were available were backed up. So it's going to take forever to even get into one. So I ended up having to go across state lines over into Kansas to get access. But I will just tell you that the support that I got is what made the difference. So I really, really hope that you all are thinking about this in terms of how can we support community members.
Yeah, I think mine was like, I'm of course here in St. Louis. I think access looks a little different here because for me, it was like a moment with an X. I literally got PEP in 15 minutes. I, went from my house to call the person. And then from there, it was let's get on PrEP. And I think like it just that brings a lot of conversation around access and availability and creating more systems that just kind of open that up, because even still here I created the PrEP project that kind of focused specifically on getting more Black MSM on PrEP, because #BlackGuysPrEP. I have the t-shirt in my room. But yeah, so I think that is very important conversation.
The last thing I'll say is I really want to encourage those of you who are remaining and who may see this recording, think of PrEP as a gateway to wellness, a gateway to healthcare access, and as a means of drawing people into broader healthcare. We have 2 patients that didn't even know that they were diabetic, but because of some of the other things that we've been able to bring into care through PrEP. Again, they came to us for PrEP. We helped them discover through the process that they were, had diabetes and had no idea. So it can be a gateway to wellness for sure.
And I think like the empowerment piece that you talked about is that's like the major piece, like giving somebody the autonomy and like power over like, this is a choice that I'm making. This is how it supports me, and it's not just take this pill so you don't get HIV,
One way we have drilled down on that piece with empowerment is that we actually have empowerment coaches who are peer mentors. And I'm very proud to say that the first folks who signed up to go through our empowerment coaches program to be a peer mentor to those who are on PrEP were 6 men who are living with HIV. They were the first ones to sign up to be empowerment coaches because they know that they can help others not have to go down the path they've had to go down in terms of their interfacing with the healthcare field. So in any event, I don't see questions, so I won't keep talking. God knows I can. God knows you can, Tyrell.
I can.
I see our MATEC team is like, all right, fellas, wrap it up.
Yes, right.
Don't me to look like my producer on the radio show. She's like, break.
Yes, that's right. My stomach is like, is it breakfast time yet? So that's what I need to go nourish myself.
All right.
No,
Well,
this has been
thank you both
amazing.
so much. Again, we're looking
you.
forward to having you on Thursday. If you'll just kind of hang on just a second as